Good afternoon, everyone. I'm excited to be here today, and I'd like to thank the organizing people for giving me the opportunity to present today. We have no relevant disclosures. Psoriasis is associated with an increased risk of cardiovascular disease, and it is hypothesized that the mechanisms underlying psoriasis and the associated chronic systemic inflammation accelerate the development of CVD, including thrombotic events. However, it is unclear if systemic therapies that treat psoriasis also reduce the risk for thrombotic events. So there are several challenges to studying CVD outcomes in psoriasis. First of all, you need a very large patient population to have the power to detect differences in CVD events. You also need a long follow-up period to allow for enough time for events to occur. And there's also several confounding factors like comorbidities associated with psoriasis, as well as medications like statins that could impact your outcomes, which can complicate your analysis. And of course, all of this could get very expensive. So our aim was to utilize the TriNetX database to investigate the effects of systemic therapies on the risk of thrombotic events in psoriasis patients compared to those treated with topical corticosteroids within 5 years of initiating treatment. So to investigate this question, using the TriNetX database platform, this includes over 100 million anonymous patient medical records in the United States. We're able to adjust for age, sex, weight, race, several comorbidities like CKD, alcohol use, smoking, as well as medications like aspirin, antilipemic agents, and anticoagulant use. We identified 700,000 patients with psoriasis in the database diagnosed with psoriasis between the ages of 18 and 80 years old. We excluded 500,000 of those because they were not on single agent therapy during our study period. So then we pulled out groups who were on systemic therapies as well as a group on topical corticosteroids. And this is people who initiated treatment with this agent within 1 year of their initial psoriasis diagnosis. We then propensity match scored each group of systemic therapies to topical corticosteroids. So we had one systemic therapy patient in each group that was matched to a topical corticosteroid patient. So this is a complex slide, but I'll guide you through with some arrows. First, let's look at the deep vein thrombosis. We saw that IL-17, which is in green, and the IL-12/23s or 23s in gold, had a protective effect relative to topical corticosteroids as they're to the left of the dotted line, whereas methotrexate in blue and is to the right of the line, meaning there is an increased risk of DVT. Next, looking at acute myocardial infarction. This was reduced for the IL-12/23 or 23 group as well as apremilast. And then looking at lab outcomes, I'll just highlight that methotrexate, again in blue, is to the right, meaning that there was an increased risk of thrombocytosis or elevated platelets relative to the topical steroid group. So to summarize the findings, methotrexate was associated with an increased risk of thrombotic events as well as thrombocytosis. Apremilast and anti-TNF-alpha had some protective effects. IL-17 showed a reduction in several thrombotic events, and the IL-12/23 and 23s protected against the most thrombotic events as well as new onset thrombocytosis. So in conclusion, biologic treatments could potentially reduce the thrombotic events, and there may be differences in the protective effects between drugs, but we're not powered to detect differences between drugs for this study design. Methotrexate was associated with an increased risk of thrombotic events, and further studies investigating the systemic therapies of CVD and psoriasis and the underlying mechanisms is warranted. So I'd like to thank Dr. Kevin Cooper, along with the rest of our lab members, for their help on this project. And I'd also like to thank the IPC for the opportunity to participate in the International Fellowship Program. And after this meeting, I'll be heading to Madrid to work with my IPC mentor, Dr. Gonzalez-Cantero, who we actually had the pleasure of hosting a couple weeks ago in Cleveland. And we look forward to establishing our international collaboration with him. And I can take any questions at this time. Thank you.
Thank you. Thank you. We have a question.
Thank you very much, Nick Reynolds, Newcastle. Very interesting data. I wonder how you can control for the severity of the psoriasis.
Yeah, so that's not a variable recorded in TriNetX, but you would assume the patients going on biologic therapy would have more severe disease. And we know psoriasis, the more severe it is, the higher risk you are of having cardiovascular events. But in fact, we're seeing the opposite, where they have a reduction in those thrombotic events.
Okay, thanks.
Nice work. Am I right in understanding that you focus the analysis on patients staying on the same drug for 5 years? Single agent?
So one of the weaknesses is we can't confirm patient compliance, and we don't know how long they were on the drug, but we know that they were started on it within 1 year of their diagnosis.
Okay, fair enough. But then are you concerned with the fact that you might, because then the question is, why 5 years? Depending on the mechanistic model, because you could have a trigger effect. It's based on immunocardiological schemes for at least arterial thrombotic events. That's one. I don't want to be too long, but that's my concern in your analysis. And how many patients did you exclude who stayed less than 5 years and who might have been stopped from any drug because of a serious adverse event, including a thrombosis or at least MI or something? I mean, that's my... a referee might look into it.
Yeah.
Hi, Nicole Ward, Vanderbilt. So as you're probably aware, there is still some contention about whether or not psoriasis patients are at increased risk for developing cardiovascular disease. Some people believe it, other people don't. When you looked at your data, did you compare your psoriasis patients with non-psoriasis patients to see if the risk was changed in terms of a thrombotic event, in terms of an MI or a stroke?
We did not for this study, but that would be another interesting analysis to perform as well.
Okay. Okay, thank you. Thank you so much. Okay.